Welcome to today's episode of the Zedu Coaching Corner. I'm your host, Sue-Ann Pascoe, and if you haven't already done so, please subscribe to our YouTube channel. And for all the ultrasound educators out there, sign up to our Facebook community, the POCUS Educators and the Seed Support Network. I just want to let everyone know that this session is being recorded and will be available on our website in the next few days, along with all our other previous episodes of the Coaching Corner. And you can find it under the resources tab on our homepage at ultrasoundtraining.com.au. Feel free to ask me some questions as we go, but if you'd rather ask those questions offline, let me know and we can come back to them at the end of the session. So tonight's topic is going to be how to evaluate pain and bleeding in first trimester. And I think this can be a tricky topic as there's many things to assess and they're kind of all happening at the same time. So I want to take you through my approach to the early pregnancy assessment scan to assess for pain and bleeding. Essentially, when a patient presents with a positive pregnancy test and they have pain and bleeding, there's one of four things that can be happening. It can be a completely normal intrauterine pregnancy. And so even in normal pregnancy, there can be a lot of pain with stretching of the joints, and some people will spot the whole way through their pregnancy. So sometimes we'll find something on ultrasound, and other times it'll be completely normal, which is good for the patient. The big one we worry about is the ectopic pregnancy. It could also be the same signs and symptoms could also be indicative of a miscarriage. And then the other one that's a little tricky is it could be indeterminate, and that is just that at this particular point in time, it's a bit too early to see, and we can't actually give them an answer, which can be frustrating for your anxious pregnant mum who just wants to confirm whether this pregnancy is progressing normally or not. But sometimes we just can't tell them the answer today. And so the indeterminate scan can be quite tricky to figure out how to proceed. So we'll start by looking at the normal intrauterine pregnancy and what the sonographic appearances are of a normal intrauterine pregnancy. The first thing we look for is the decidual reaction or the trophoblastic ring. We want the gestational sac to be eccentric in location. So not in the midline of the uterus, we want that to be burrowing into the endometrial lining. You should see a yolk sac and a fetal pole with or without a heartbeat. The first sign that we see, and this is on transvaginal ultrasound, is a little fluid collection or a little cystic space eccentrically located in the endometrium. This small round fluid collection is surrounded by a hyperechogenic rim of tissue. That central fluid collection is a chorionic cavity, and the surrounding hyperechoic rim of tissue is the developing chorionic villi and the adjacent decidual tissue. Now, this is tricky at first because we can't really positively differentiate this from a pseudosac associated with an ectopic pregnancy. And so if this is the only thing we saw, it would kind of fall into that indeterminate range because it doesn't have all those features that we went through on the last slide of the yolk sac or crown rump length with a heartbeat to categorically say that it's an intrauterine pregnancy. But if we catch it early enough, this is what we see. 5 weeks, 4 days, we see the yolk sac appear, and that kind of dates the pregnancy definitively. If that's the only thing we can see, we know it's at least 5 weeks, 4 days. And so again, we're looking for that double decidual rim of tissue and the yolk sac. Differentiation of a pseudosac from an intrauterine pregnancy will be determined by the presence of this yolk sac. So once we see that yolk sac, we start to know that this is definitely an intrauterine pregnancy. So here's sort of the inner layer of the decidual ring and the secondary layer or the double decidual layer of the trophoblastic reaction, and we have the yolk sac just here. The next sign that we see at 6 weeks, and these pictures are all transvaginal, which is the best way that we can assess it in those very early stages of pregnancy. The next sign that we see is like a diamond ring appearance. And this is where the embryo is just a couple of little lines and it's just flickering. We just have the heartbeat really, and it's only a couple of millimeters. And you'll see that little crown rump length sort of sitting adjacent to the yolk sac. For us to definitively confirm that this is an intrauterine pregnancy, we should see the double decidual ring, the crown rump length with a heartbeat, and the yolk sac. And we're looking for that little flicker there to tell us that this is a viable intrauterine pregnancy. So after that, if we start from, okay, they've had their last period, the first signs we see is the little tiny cystic space, which is a very early gestation. So this is at 5 weeks. 5 weeks, 4 days, we see the yolk sac. At 6 weeks, we see the diamond ring, and you can see why we think it looks like a diamond ring there. At 7 weeks, the fetal pole looks like a peanut. It's a little bit longer and a little bit more substantial, but you can't differentiate head or tail here of the crown rump length. At 8 weeks, I reckon it looks like a little Lego brick. So at this point, we start to see the little limb puddle, the little limb buds forming. At 9 weeks, the fetal head is almost half of the crown rump length. And so it looks a little bit like Megamind here. And now we start to differentiate that one end, and on this picture, it's the end on the right of screen. That looks to be the head, the other end, the tail. By the time the embryo is 10 weeks, you can see definitive human features. And this is when we can tell the difference between a human embryo versus an elephant embryo versus a puppy dog embryo. Up until that point, we all look the same. All mammals look the same. But at 10 weeks, we can start to see this one is human. At 11 weeks, we have ossification of the cranial vault. And so you start to see the perimeter or the very rim of the skull bones there. And when we get to the 12-week mark, we should start to see ossification of the jawbone and differentiation of the different bones, long bones of the arms and legs. And if you're looking, you can start to notice things like the bladder and the stomach and fingers and toes. So the reason I take you through these appearances of the gestation, a week-by-week approach, is when we're scanning, what I tend to do is have a look at what I'm seeing embryologically and what has formed embryologically, and I'm making a rough estimate of the fetal age. So I want to be able to guesstimate, if you like, with a 2-week sort of room for error, just by looking at the fetal development, how far along this gestation is. And that's because one of the common mistakes that people make when they're just learning to do crown rump lengths is they make very inaccurate measurements, because they either include the yolk sac as the fetal head very early on, or they're taking an oblique cut, and so they foreshorten the crown rump length. And if we get the dates wrong at this stage, it kind of sets it up for the rest of the pregnancy. And so we want to try to estimate the gestational age by looking at, well, what fetal development milestones have been reached, what anatomy can we see, and then we correlate that with our crown rump length. One of the big things we're always worried about, especially in early pregnancy, is if there's an ectopic pregnancy. And so on this image, you can see the endometrial lining, and it's quite echogenic here. We can see the outline of the uterus. This is a transabdominal image. We have quite a bit of free fluid hanging around in the pouch of Douglas, and then we have this adnexal mass here. So the key giveaways on this image is that we cannot see anything within the uterus, and there's free fluid present. And you could be forgiven at a quick glance that maybe that looks like an ovary, but they have a very different looking texture about them. And so the key giveaways are the empty uterus and the presence of free fluid in the pouch of Douglas. The role of ultrasound, particularly in the emergency room, is to rule in an intrauterine pregnancy rather than ruling out an ectopic pregnancy. And the reason we want to rule in the intrauterine, the chances are very low. If you have an intrauterine pregnancy, the chances are very low that you would have a coexisting ectopic pregnancy. Now, the caveat on that for the Indigenous population, because they have a higher incidence of pelvic inflammatory disease, and for patients who are undergoing IVF treatment because they have fertility issues for whatever reason, potentially it's because they have blocked tubes. So if we're looking at how to assess for an ectopic pregnancy, if we can rule in the intrauterine pregnancy, the chances of a coexisting ectopic pregnancy are very slim, like less than 2% or something. To try to rule out the ectopic pregnancy, even in the hands of experts doing transvaginal examination, ectopic pregnancies can be missed in up to 10 to 15% of cases. So by ruling in the intrauterine pregnancy, we have a better chance of ruling out the ectopic pregnancy. So looking at this uterus, we can see it's an empty uterus with a sneak of fluid within the endometrial cavity. It certainly doesn't look like a thick and juicy endometrium associated with a secretory phase endometrium or a pregnant endometrium. So that's a giveaway here. And then we have free fluid down here in the pouch of Douglas, and we also have some free fluid in this anterior cul-de-sac. Ectopic pregnancies can look very different depending on where they implant. And so if you're looking at a cervical ectopic pregnancy, it will look very, very different to if we're seeing one in the tube, for example. And the incidence of cervical ectopics is, we're seeing them a little bit more commonly now because there's a lot more cesarean sections. And so I've seen a couple now, and they used to be a really rare thing when I started training, but I've seen a couple now in the cesarean scar. And so it's really important that we assess the uterus in its entirety and then look very carefully in the adnexa, trying to find the ectopic. If we see an adnexal mass, even if we can't definitively say, well, that's the ectopic, the presence of that adnexal mass without an intrauterine pregnancy is strongly suggestive of an ectopic, and you manage it in the same way as if it was ectopic until you prove otherwise. The classic sign of an ectopic sitting in the tubes is the donut sign or the bagel sign, depending on which part of the world you're from. And so you can see here on this transvaginal image, we have the edge of the uterus kind of coming over this way, have ovary here, and then here is the ectopic. And on this side again, a different patient, we have the uterus, the ovary sitting in here, and then this sort of cystic sac space sitting between the uterus and the ovary. The giveaway here, again, is the empty uterus and the presence of free fluid. And as we look through the adnexa in this patient, we can see what appears to be a ectopic pregnancy with the yolk sac, and maybe you can even imagine a crown rump length there. And this area here is an area of blood clot. Here's an example of an adnexal mass. It doesn't have that classic donut appearance. We certainly can't see the decidual reaction and a cystic space associated with a gestational sac, but we have a complex mass here. And so we manage that as an ectopic until we can prove it otherwise. Now, the ectopics can also implant in ectopic locations within the uterus, either in the cervix or in the cornu or the interstitium of the uterus. And you can see this example. This lady happened to present at her GP on a day when someone was there doing applications training, and a very experienced sonographer was doing the scan, who had very good technique. I think otherwise it could possibly have been missed, but this lady was gravida 6, para 5, and we saw this 10-week gestation sitting right up in the cornu of the uterus. And so what gives it away here is the thickness of the myometrial mantle here being quite thin. In the normal pregnancy, that should be at least 5 millimeters or more. In this instance, it's very thin, and it gives away that that presentation of the pregnancy is in the wrong spot. Here's another example of an interstitial ectopic. So we have the endometrial lining over here, and then at the edge of the uterus, this more classic sort of donut appearance of the ectopic pregnancy. Sorry. We also have a cervical ectopic. So as we're scanning through here, you can see nothing in the fundal part of the uterus, but down here in the lower segment, you can see as we scan through that the pregnancy is sitting quite low, and it's sitting in the cervix there. Now, the thing is, when you have a patient that has a low blood pressure and they present in pain, it suddenly doesn't become about finding a pregnancy. It's all about the FAST exam. And this next place, if you see free fluid in the pelvis, the next place you would look is in the right upper quadrant. This is for the women. This is the second deepest part of the peritoneum. So this is where the overflow of fluid will sit. And fluid in the right upper quadrant has a high predictive ratio that they need surgical intervention to fix it. So the likelihood ratio is something like 112 times the likelihood ratio that they need a surgical management to fix the problem. And so the technique is the same for the right upper quadrant view of this, the FAST exam. We're putting the probe on at about the level of the xiphisternum and the mid-axillary line, and we're scanning through the right upper quadrant to identify fluid sitting between the liver and the kidney in Morrison's pouch. And if we see a 0.5 centimetre strip of fluid here, it roughly equates to about 500 mils. A 1 centimetre strip equates to about 1 litre of blood. And so, as I said, if you find fluid in the pelvis, then we're going up to the right upper quadrant. This suddenly becomes a bit of a hurry getting you to theatre rather than worrying about trying to find the ectopic. And so the other possible scenario, if someone presents with pain and bleeding, is that they have a miscarriage. And so the pregnancy failure criteria state, and this is based on the ASM guidelines, on transvaginal examination, you either have no fetal heartbeat and the mean sac diameter is bigger than 25 millimeters, or your crown rump length is bigger than 7 millimeters and there's no fetal heart rate observed over a 30-second period, or you're doing a follow-up exam and there's been poor or absent growth over a week. So the critical numbers here is once the mean sac diameter is 25 millimeters, we should always see a crown rump length with a heartbeat. Once the crown rump length is more than 7 millimeters, we should always see a heartbeat. And so there are many different options of miscarriage. We have inevitable miscarriage here, where we can see a really misshapen sac in the lower segment of the uterus. I have scanned a lady one time who I could see the heartbeat, but I could also see the peristalsis of the endometrium as the sac was moving down the endometrial canal. And so it's kind of tricky because you know that it's inevitable that this is going to come out, but we could see a heartbeat at the time. Sometimes it's a missed miscarriage, so the body just hasn't recognized that it's not progressing normally to pass the products of conception. So what I'm looking for in a missed miscarriage is the size and the shape of the gestational sac. So remember, our gestational sac, once it's bigger than 25 millimeters, I should always see the yolk sac and the crown rump length. So what I'm looking for here, in this instance, the average or the mean sac diameter here ended up being about 32 millimeters, and we couldn't see a yolk sac or a crown rump length at all. So we could categorically say that this is a missed miscarriage. The other thing that might be happening, and happens quite often, is that they can have pain and bleeding and they can be threatening to miscarry, and we can see perigestational bleed, but it's not necessarily, we aren't crystal ball gazing and we can't necessarily say that definitely it will miscarry. All we can do is comment on the day what we've seen. And so in this example, we have the vaginal stripe here, an anteverted uterus with the gestational sac. And the crown rump length there is probably about the 8 to 9 week mark. And just around the edge of the uterus here, you've got this curvy linear hypoechoic space that conforms to the edge of the sac and sits between the edge of the chorion here and where it should be implanting into the endometrium. And so if that perigestational bleed is over about 40 to 50% of the perimeter of the gestational sac, then it's thought to have a poor outcome. But we can't categorically conclude that it's going to miscarry. I have seen some that have hung on and they've progressed to be a normal pregnancy. So once again, we can only comment on what we see at the time. So what we're looking for is any hypoechoic areas that sit adjacent to the gestational sac. And often if we scan these in a couple of weeks, they start to resolve. And I explain this to my patients. It's like when you kick your shin, you get a bruise, your body takes care of it, and we often see them disappear over time. The next one that's kind of, in some respects, an easy diagnosis, not an easy answer for the patient, of course, but when we see a definitive crown rump length and we don't see a fetal heartbeat. And so you can see this gestation's about 8 to 9 weeks, and in the region where we should see a heartbeat, we're seeing no fetal heartbeat. Here's another example, slightly smaller, maybe 7 or 8 weeks, and we can't see a fetal heartbeat in the middle of the baby there. The challenge, though, is when we don't meet those critical thresholds and we have an indeterminate pregnancy. And this is challenging from a diagnostic point of view and knowing what to do to manage them, but it's also very challenging insofar as communicating that with your patient, because they want an answer and they want an answer today, and sometimes we just can't get there. And so this grey zone exists between that sort of 5 to 8 week mark, where depending on your patient's body habitus and the way you're performing the scan. So if you have a larger patient and you can only perform a transabdominal scan, it's going to be difficult to see that pregnancy before that sort of 6, 7, 8 week mark. And so that grey zone between 6 to 8 weeks, where we have to be really careful so that we don't miss an ectopic pregnancy. But mum wants an answer and they're very anxious to know about the pregnancy viability. And sometimes we have to say, you know what, you have to come back in 7 to 10 days' time so that we can get a better look. And so the plan here, if we don't meet those critical thresholds of being 25 millimeters mean sac diameter and 7 millimeters crown rump length with a heartbeat, the option here is that we need to rescan them in 7 to 10 days. Now, from a medical point of view, you can also be monitoring their beta HCG levels and making sure they're going in the right direction. But otherwise, we just have to wait and let time for bub to grow. And so here's an example where the gestational sac was around 24 millimeters mean sac diameter, and the crown rump length was 3 millimeters. And so I can't see a heart rate or heartbeat in that tiny little bump here. That's probably the crown rump length. But we haven't met that critical threshold, so we just need to wait a week. And the reason we wait a week, the gestational sac will grow by about 1 millimeter per day, and the crown rump length grows about 10 millimeters per week. And so if we wait a week, now our baby has a chance to grow to be bigger than what the threshold values are, so that we can categorically determine whether this is an ongoing viable pregnancy or not. Here's another example where the patient was 8 weeks, 4 days by dates. The gestational sac here had a mean sac diameter of 13 millimeters. And as we go through the scan here, as we sweep through, I think the yolk sac's just in through there. I think it comes back again. Here we go. But we haven't been able to see a crown rump length, and certainly haven't seen a fetal heart. So we need to repeat the scan in 7 to 10 days. Here's another example, 9 weeks by LMP. And I think the problem here sometimes is that our patients know when they're 5 minutes pregnant now. The pregnancy tests at the supermarkets are so much more sensitive these days than they were 20 years ago. The expectation of technology is so much higher than it was 20 years ago. And so people want answers. And the way that the gestational dating is set up is it goes from the first day of the last period, assuming that everyone has a 28-day cycle. So it's easy for someone to present to me saying that they're 7 or 8 weeks and they only measure at 6 weeks, and it to be an ongoing viable pregnancy with nothing wrong, because they just have their dates wrong and their periods been unusually long, or is just regularly long for them. Our machine, when we put the data in, assumes everyone has a 28-day cycle. So if you question your patient and you understand that they have a 40-day cycle, you should probably be entering the data into the machine based on their EDD rather than using the LMP. So this patient was 9 weeks by dates, and when we scanned her, it looked quite early. And then a week later, we scanned again, and there was no change in the pregnancy. So we couldn't see the yolk sac, we couldn't see the crown rump length. And so now we can categorically call this that it's a failed pregnancy. Here's another example at 6 weeks. Now this one's got an unusually large yolk sac in proportion to the gestational sac, which can be have quite a poor prognostic sort of sign. We can't see the embryo, and we wait a week, and 6 days later, it's the same situation. We can't see an embryo. There's certainly no fetal heart rate. So we can categorically say this is a failed pregnancy. The other term that comes up often is a pregnancy of unknown location. And so in a woman with a positive pregnancy test, but there are no signs of an intrauterine or an extrauterine pregnancy and no obvious retained products of conception, if we see that on a transvaginal ultrasound, we call it a pregnancy of unknown location. So positive pregnancy test and no definitive intrauterine pregnancy seen on a transvaginal exam. Now, a pregnancy of unknown location, or PUL, is a sonographic description of findings and not a pathological description. Under these circumstances, there's 3 possible outcomes. It could be a very early intrauterine pregnancy that we just can't see yet. It could be an ectopic pregnancy, or it could be a failed pregnancy of unknown location. And so we need to monitor these patients and get them back in a week, or keep scanning them until we have a definitive answer about where that is, so that we don't miss the ectopic pregnancy. So now I'm going to take you through how I approach the scan. Now that we've got a bit of context around it, I'll take you through the way that I approach the scan and the structure that I apply to my scan technique. The goals of that early pregnancy scan are to locate the pregnancy, establish viability, detect multiple pregnancy, and to establish their gestational age. The first step we do is we choose the right probe for the job. And so in that sort of grey zone, in that sort of 5 to 8 week mark, it's preferable that we do a transvaginal examination. Depending on your patient's body habitus, it may be preferable that you need to do a transvaginal examination. But on some people, we can see things quite nicely with a transabdominal, and perhaps that's the only probe that you have available to you. So you need to choose the right probe for the job. You need to set your machine up right and choose the right preset, which is the obstetric preset or an early pregnancy preset. Now, some machines have early pregnancy or 2nd and 3rd trimester presets. The difference here, your early pregnancy setting will give you access to crown rump length and gestational sac, whereas your 2nd and 3rd trimester preset gives you access to fetal biometry measurements like BPD and femur length and such. And the last thing we do here in setting up for our exam is to put the patient data in. And as I mentioned before, this is where we do want to pop in the LMP details or the estimated due date, because then we've got that reference point to compare our findings against. The transabdominal scan is great if your patient's nice and slim and you can see things easily, but you will see the early indications and the early definitive signs of pregnancy about a week sooner on the transvaginal examination. And that's because the transvaginal probe is higher frequency and we're putting it right up against the uterus, so we get much better resolution on our pictures and the detail is much better. Transabdominal, we have to go through an empty bladder or through however much adipose and subcutaneous tissue there is until we get to the deeper structures of the pregnancy. So we see things about a week sooner on transvaginal exam. Now, the way I kind of think about the pregnancy is I'm looking at the uterus as baby's house. And I first want to start with my lens and my options wide, and I'm looking for life and death things first. So I'm looking for signs of ectopic pregnancy first, and then I increasingly bring my lens or my focus of attention further towards baby. And that's because as much as mum wants to know, is this a viable pregnancy or not, because it's obviously very important to them, if we find a fetal demise, it's not a surgical emergency. It's not a life-threatening situation. It's very sad, but it's not life-threatening. Whereas an ectopic, we need to get onto that really quickly. And so I think of the uterus as baby's house. And the first thing I'm going to do is look at all of mum's anatomy and look outside baby's house. I then look at baby's house, then the gestation, and then focus on the embryo. So we start by looking outside the house, scouting around in the adnexa. We're looking at the ovaries, the adnexa, and the cervix. Is it open or closed? Then we focus on the uterus and bring our attention more centrally towards baby. So those steps again, step 1 is focus outside the uterus. Step 2, focus on the uterus. Step 3, focus on the gestation. And last but not least, focus on the fetus itself. Now, at each stage here, I have a series of questions that I'm asking myself to get to the point about whether I think this is a viable intrauterine pregnancy, a miscarriage, or an ectopic pregnancy. And so when we're focusing outside the uterus, we're looking for, is there any signs of free fluid? Is there any, or can you see the corpus luteum? And which side do you see the corpus luteum on? Because most pregnancies or most ectopic pregnancies will occur on the same side as the corpus luteum. And we're also looking for any adnexal masses. Then when we look at the uterus, we're trying to see if we can see an intrauterine pregnancy, and if so, how many? And is there any other pathology? So can we see any fibroids? Is the cervix open? Then we focus on the gestation. I'm specifically looking at the position and the size of the gestation. I'm looking to see if the gestational sac is smooth and regular, and I'm looking for any signs of perigestational bleeding. And lastly, we look at the baby and we try to see if we can see the yolk sac, can we see a fetal heart? And then we estimate the gestational age, as I went through before, and then measure the crown rump length. So step 1, to focus outside the uterus. Can we see any free fluid? Can we see the corpus luteum? Are there any adnexal masses? And this is where we need to do a good thorough scout scan. We need to look through the adnexa and make sure we extend our scan from the iliac vessels on one side all the way to the iliac vessels on the other side, inferiorly and superiorly past the fundus of the uterus. It's really important that we have a good look in the adnexal regions here, looking for any signs of an adnexal mass. And so a position, when I'm looking for the adnexal mass, I want to be able to visualize all the way out to the iliac vessels. I want to position my scan so that the uterus is on the edge of my picture as a reference point. You can see the ovary here, and we're trying to examine all this area here to make sure we can't see any signs of an adnexal mass or ectopic pregnancy. And so we need a good thorough scan and sweep through in the longitudinal plane and in the transverse plane. I typically start in transverse because the lens is wider and you can see more at once, and then proceed to a longitudinal sweep. We look for the corpus luteum. So you can see on the left just the B-mode image of the corpus luteum. If you are doing a vaginal exam, you can use the color Doppler to identify the ring of fire, they call it, or the hypervascularity peripherally around the corpus luteum. So the corpus luteum is a thick-walled cyst with that characteristic ring of fire and peripheral vascularity. Step 2 is to focus on the uterus. So we're looking to see, can we see an intrauterine pregnancy? How many is there? And is there any other pathology such as large fibroids? So in this instance, can we see an intrauterine pregnancy? The uterus appears empty. To be concerned about whether there's an ectopic here, or it might be just too early. We're looking to see that there's something in the uterus, and every now and then you'll find more than one. Then we move on to the gestation itself. We want to look at the position, how big, and measure the mean sac diameter, and then look to see if there's any perigestational bleeding. So the first thing is the size and position. The image on the left, you can see that the gestational sac is well located within the fundus of the endometrium there. The image on the right here, this smaller gestational sac is sitting right out at the edge, and there's not a very thick myometrial mantle here. We also see a little bit of free fluid. So as much as that is in the uterus, it's in the wrong position in the uterus. We look at the decidual reaction. I want a smooth, round, nice and even, healthy looking gestational sac versus raggedy edges, deflated, disrupted decidua. And then we look for perigestational bleeding. So this example on the left is normal. And here's an example on the right. We have that curvilinear hypoechoic rim that conforms to the shape of the gestational sac. And last but not least, we look at the fetus. And first of all, we want to identify the yolk sac. And you can see the little tiny one just here. Then we're looking to see whether we can see the crown rump length and can we see a fetal heart, and we'll document a fetal heart trace. And then lastly, we'll measure the crown rump length. And I like to estimate, as I said, estimate it at first glance by what embryological development can you see, and then measure it. And I take a new image 3 times and measure 3 separate crown rump lengths so that I know I'm getting a good, honest measurement that's accurate. So those steps again were to start with our lens out wide and look outside the house, focusing on the adnexa and looking for free fluid outside the uterus. Then looking at the uterus itself, then looking at the gestational sac, and lastly looking at the baby. And the questions that I'm asking when I'm looking outside the uterus: is there free fluid? Which side is the corpus luteum on? Because if I can see the corpus luteum, I have a really good long look at that adnexa to make sure there's no adnexal masses. Although I don't ignore the other side, because it's some of the studies I was looking at, anywhere between 5% and 28% of ectopics happen on the contralateral side to the corpus luteum. But most of them happen on the side of the corpus luteum. And we're looking for adnexal masses. When we focus on the uterus, we're looking to see, can we see an intrauterine pregnancy? How many are there? Is there any other pathology? What's the position and the size of the gestation? And now we're focusing on that gestational sac. Is it smooth and regular? Can I see any perigestational bleed? And lastly, is there a yolk sac? Can I see the fetal heart, measure it, and then estimate the gestational age and measure the crown rump length? So when the patient presents with this triad of symptoms, there can be 4 possible outcomes. And we've taken a look at what the criteria are, or what a normal intrauterine pregnancy looks like. We've looked at some examples of ectopic pregnancy. We've looked at the pregnancy failure criteria, and also the tricky one when it's indeterminate and we can't give our patients an answer today. So hopefully that structure and approach to your ultrasound can help you come to the right diagnosis and allow you to appropriately manage your patients. So that brings us to the end of our presentation. If you liked this episode, feel free to share it with your colleagues and subscribe to our YouTube channel, where you'll find all of our previous topics. And if you have suggestions for a topic in the future that you want to hear about, please get in touch either via my email or on the socials. And now is where I open up to see if any of you have any questions. Does anyone have any questions or comments?
I've given enough time for everybody else, so I'll ask a quick one. I find that this application of point of care ultrasound arguably is like the most important and useful one in the emergency department. We focus so much on fast exams and aortas and all that stuff, but this is where you see a couple of these patients a shift, and it's highly satisfying for patients when you can find an answer. But I have to admit, I do exactly like you do. By the way, there's an excellent presentation, which is I'll basically just focus on making sure there's an intrauterine pregnancy, and if it's looking for viability, and by definition, sort of exclude an ectopic pregnancy just based on that. A couple of really quick questions. I always get nervous about missing a scar ectopic or an interstitial pregnancy, and calling it just a normal IUP and then having some catastrophe happen. Any tips or tricks to well, you sort of mentioned about the interstitial pregnancy, but about the scar topics, anything, any other tips you can tell us to kind of minimize those errors?
I think it's having a really good scan technique. So making sure you scan through in longitudinal from left to right or right to left, whichever way you go. And then in transverse, making sure you scan all the way down to vagina and working your way up so that you can see the, you look in the lower uterine segment looking for, and particularly it's much easier on transvaginal exam, obviously, because we will often see the ectopic, the Caesar scar, but it does require a really thorough technique. And, when I see these, Women's Day articles where they've missed a twin, my first thought is they haven't scanned through the uterus in its entirety. And so the best way to avoid that is to go from lateral wall to lateral wall, inferior to superior. And you get used to looking at where fundus is versus cervix, I think. Any other questions?
A couple of questions, Sue-Ann. Thank you for the presentation. How do you, probably a bit slightly esoteric, but I'm just not quite sure. How do you distinguish between a corpus luteum and an ectopic in the ovary? Because wouldn't a tubal ring in the ovary and a corpus luteum look very similar?
So that is absolutely a transvaginal diagnosis. And what we do when we're doing the transvaginal diagnosis, if I put pressure, if I see an adnexal mass, if I put pressure on it and it moves together, then it's on the ovary. Whereas if I poke it and it moves separately, it's in the tube.
But can't you have, I think, wasn't there a small percentage where the ectopic actually happens in the ovary? I think there's a very small percentage. It might have been 1% or something like that.
It is a small percentage that happens in the ovary. But again, that's going to be a transvaginal diagnosis.
Okay.
The focus of the transabdominal scan is to find the free fluid and exclude an adnexal mass if you can see it. But to be honest, transabdominally, that's really challenging. So you're looking for free fluid. And certainly I have some personal experience of this. I had an ectopic. It was a fast exam. It wasn't looking for the intrauterine pregnancy, or we saw nothing in the uterus, but it was all about the fast exam. So it's those stable ones that end up in the imaging department that you can do a transvaginal scan on that will sort those ones out, whether it's on the ovary or in the tube.
The one picture that you showed with a fairly big gestational sac and nothing in it, being a failed pregnancy or a missed miscarriage, for us in the ED, or anyone else, we would only know that if there was a previous ultrasound that showed an intrauterine pregnancy, wouldn't we? Because if that's the first scan that's being done, how are we going to know that that isn't a pseudo-gestational sac and an ectopic pregnancy?
So the things that you look for is the double decidual ring, which can be quite subtle, but the other thing about this is the size. So if that's the only scan you're doing and you've seen that it exceeds 25 millimeters and you see a yolk sac, well, then you can categorically call it. If you don't see a yolk sac, you're probably going to need to follow it up.
Because it could still be either by definition, could it?
Theoretically, but typically the pseudo sacs associated with ectopic pregnancy,
pretty small.
They're small, they sit very centrally, and they don't have that trophoblastic reaction. So they don't have the bright white halo, if you like, around them.
Yeah. So, Anne, can I make a comment and see if you want to comment with us, and see if Alan has any comments as well? You talked a lot about transvaginal sonography, which is, of course, obviously higher frequency, you get better quality images. Here in Australia, it doesn't seem like we're doing much in the emergency department. We're not doing much transvaginal sonography. There might be some exceptions. one tip or trick that I've had is in your thinner patient, I have been able to switch to a linear array, ideally one that has a little lower frequency ranges. And you can actually get some better detail and actually make up your mind. Yes, that is definitely a yolk sac. Okay, I've confirmed that this is an intrauterine pregnancy. I don't know if others have had that similar experience.
Yeah, I've done that as well, Brian.
Yeah.
I have to say I haven't, but I would just go to a transvaginal pregnancy because I have it available and have the skills. But that's a very valid way that you could. It would work in your thin patients, and depending for those, it depends how their uterus is sitting. If it's close to the surface and not, if it's going deep and you're going through bladder, it's probably not.
You don't want the bladder to be too full for that technique, because it'll push it away from you. The other point I would make to the other listeners is be very careful about the idea that you can clinically pick the leaking ectopic, because I've had a number of patients that have had 100 mils, 200 mils, 300, 400 mils of blood in their peritoneal cavity, and I've also spoken to colleagues who've had the same, and those patients can look absolutely fine. They're physiologically very fit young females. Their hemodynamics can be fine. Their pain can be mild. Their tenderness can be mild, and you just can't see any difference between any other patients that come in with a threatened miscarriage. So I think, for me, it's what you said, is that I strongly encourage all of my trainees to do a fast scan on every single first trimester patient that comes in, because if you miss a non-leaking ectopic, you got to be pretty unlucky, even if it's a couple of days that you're waiting for an ultrasound to be done formally for the patient to have a problem. But if you send them home and they're already leaking, you pretty much are asking for a disaster to happen. So I think they're just got to be really cautious around this, taught idea in textbooks and in lectures and in our training that you can clinically pick the leaking ectopic, because I've seen many times you cannot.
This for me personally gives me the tingles, because I know for mine it was very sudden. It almost was like I felt a pop. I had absolutely no symptoms beforehand, and from pop to being in theatre needing an urgent laparotomy was about an hour and a half. So it must have been leaking before that. I didn't feel anything. It was all normal. I did not have the shoulder tip pain. I didn't have all those classic signs. I had no bleeding. So, there's such a variability of presentation here. And, this, like we said, this is an important topic. It's really good to be able to reassure a patient that, yes, everything's going well. It's also good to be able to find those catastrophes before they happen. But I think the important thing is to have a good structured approach so that you're not missing things. Because if you can get the right answers, that's great. But unfortunately, I see that this area of ultrasound in particular is kind of a bone of contention with a lot of sonographers, the point of care use of first trimester ultrasound, because that's the most likely place where you're going to make mistakes, where you say, oh, I saw a heartbeat and there wasn't, or I didn't see a heartbeat and there was. So you cause all this anxiety, or you miss an ectopic. And so it is useful to remember, visualizing the ectopic is a transvaginal diagnosis. I look for pictures all the time, looking for transabdominal ones. There's not a whole heap out there because it's mostly done, and the identification of the ectopic mass itself is usually done with a transvaginal exam. And even in the hands of experts, 10 to 15% will be missed. So it's easy to miss this. Well, it's been really good to see so many on the call tonight. Thanks so much for joining me. We'll call it a day. And as I said, if you've got a topic you would like for next month's Coaching Corner, please get in touch. Otherwise, good night, folks. See you next time.